Hello and good evening. So sorry, today I posted this link bit late, so I know, uh, but I somehow missed it. So I thought that I already done it, but okay. The official disclaimer that the images which will be showing, they are only for medical training purpose and they are for educational purpose. Not all images they are suitable for audience of all ages, so that's why viewer discretion is absolutely needed. And they are for medical education, right? And they address mature audience. And kindly refrain from watching this training session if you feel uncomfortable on watching images related to medical education officially. All right, thank you. And let's start. Now, I would really insist that you keep a cup of coffee ready because what I have done is I have combined two topics. So actually in our book, right, it's like diaphragm is one topic and posterior abdominal wall is the second topic. I combined both of them. Actually, the reason is I really want you that to develop that you should be able to say sustain for say 2 hours session because there are many sessions, many topics which are so long and it is necessary to finish them in one stroke. It's fine, means we can divide it into two parts, but at times it is necessary. And I was just watching, means it was not related to medical, but there was some person who was explaining some accounts, right, live session, and it was of 6 hours. And very interestingly, that gentleman, after about 2 hours, he said that, okay, we are continuing this session. I just go, I grab some sandwiches, and he's eating sandwiches, and then once again he's resuming. So that gave me the idea that, say, being medical students, your capacity should be phenomenal. And yes, who knows, means if you wish, we can actually plan that thing on one day, right? Let's say from morning and till afternoon, say we'll start with 2 hours and 3 hours and 4 hours. How nice would it be that in a single shot, right, just in 3 hours or 4 hours you have completed such a big region. And today would be the trailer for that, right? So don't, Ankit, yeah, Ankit is there, yeah, Ankit is there. Ankit, don't tell me that enough for the today, right? Otherwise I'll come online to hit you. Okay. And one very interesting thing that I don't mind if someone dislikes, but whosoever is disliking, right, I just request him that Baba pehle video dekh to lo, then dislike it. Means it's like someone disliking it even before start of the video. That is bit funny, right? So please do dislike, but after completion of the video. Okay. All right. So I never keep anything in heart. So I thought that I must say this, so I said it. Right. I know people say that don't say such things online, but say all of you are friends, so I can always say. Okay. Okay. So let's start with diaphragm and then we'll go to posterior abdominal wall. On top of it, what I really wish is that, see, there are some very confusing areas in this. So we'll actually draw and even clarify those things like azygos, hemiazygos, how that superior vena cava and inferior vena cava systems are connected. And trust me, you know most of the part, right? Only few things are needed, and suddenly you will find that wow, lower limb, abdomen, thorax, heart, everything is in the complete synchronization, including the porta-cable systems. And then we'll understand very effectively that why those anastomosis they are occurring at esophagus or say rectum or the bare area of liver, etc. Right? Okay. So let's start. So first part, the thing what is called is that diaphragm, right? And diaphragm is between say thorax and the abdomen. Now here we say the diaphragm is like dome shaped, right? It's like dome shaped, what we drew, right? It's dome shaped. Important part is that whenever you go in any of the yoga session, they say ठीक है पेट में हवा भरिए. Now at times it is funny, right? That is when you breathe in, right? The tummy, abdomen, that should swell. So I ask that when you say that breathe in and पेट में हवा भरिए, how is it possible? It is technically wrong, right? But yes, it happens that abdominal bulges for the respiration. One important fact that the inspiration is an active process, right? It is an active process, and expiration, that is, there are two types of expiration, right? One is the normal expiration and second one is the forced expiration. So normal expiration is a passive process. No energy is used. Why we are discussing this? Because diaphragm will be playing a major role in all these things, and it is super interesting. Why passive? Because muscles relax, right? When muscles relax, no energy is used. Second, there is something what is called as the elastic recoil of lungs. Now in one of the videos of physiology we have talked about it, so that's why today we'll not talk much. But elastic recoil means it's like a stretching, it requires energy, and when that rubber band it goes back into its original state, that is elastic recoil, right? Elastic recoil, it goes back into its original state. So that's why, see, the lungs would always try to collapse, but then those that thorax, that abdominal, I'm sorry, thoracic wall, right, will try to expand. So in between there is generation of that negative pressure. It is that negative pressure which is keeping the lungs inflated. Otherwise they would deflate. So that's what happens in pneumothorax. If it is punctured, that negative pressure goes and that lung collapses. Right? This is just in very much brief, but this is to explain that what exactly is elastic recoil. Now, when we say that, yeah, then you are right. Okay, so where was it? Elastic recoil. Right? So why I said that yoga part is, it is the movement of the diaphragm. When the diaphragm goes down, because the idea is when we breathe in, idea is that large amount of air it should go into the lungs, so that's why lungs should be getting more space, so diaphragm should go low. When the diaphragm goes low, right, it generates pressure on the abdominal contents, so that abdomen swells, right? So in return, those lungs, they are getting more space, so that's why they are filled up with more air. But there is something more. This is what is called as the quiet respiration, right? Quiet respiration is, sorry, I didn't quite catch that. Sorry. So quiet respiration is what we are doing normally, right? So during inspiration, we'll see this thing in more detail as we'll be watching the say anatomy of the diaphragm. But this is diaphragm, and there would be a central portion which will be having those crusts. You can say that they are like handles, right? And diaphragm is actually a muscle. It is full of muscles, and then there is a central tendon, this central tendon. So when they contract, right, when they contract, it pulls it down. So in that process, right, say there would be IVC, inferior vena cava, because the inferior vena cava will be going from abdomen to thorax, right? Aorta will be coming from top to bottom. There would be esophagus which will be coming, right? So many, these are the three major openings. And these three openings, they are very special. So typical, that is when same muscle contracts, right? When same diaphragm contracts, inferior vena cava opening, it enlarges because it is given more space. Esophagus, there is a sphincter action, so it occludes. And artery that is aorta, there is no effect. Now, it's so interesting that how it happens. Same muscle, same area, right? It is contracting and one is given larger opening, one is obstructing and one is no effect. That's what we'll see. But just for the time being, trust me that IVC, inferior vena cava opening, because that he is given bigger space. So IVC opening enlarges. So that means there would be large amount of venous return, right? Why do you really want this venous return? This venous return, it will reach to right atrium to right ventricle to it will go to lungs, right? And in lungs, here is the deoxygenated blood, right? So here is the deoxygenated blood. And what has really happened? That during inspiration, you have already brought that good air which is having oxygen. So that's where oxygen carbon dioxide exchange occurs and the whole process continues, right? So here it is like demand and supply, right? There is demand over here and here is the supply, right? See the effect of watching those accounts videos, right? And marketing videos. Okay, so for the diaphragm, let's make it in the form of keywords so that when it is needed, you should be able to revise it fast. There is one is the sternal end. Initially, you have to visualize a bit, then we'll watch all those real images and rest of the images. Some of the images will draw, right? The coastal part and the important is the lower lumbar part. Lumbar part. So think it like this. Here it is, right? And that's the diaphragm. So over here, that would be the sternum and this would be the xiphoid process. So just nothing much. The sternal portion is just behind this, right? There are two slips and they are taking part in the formation of diaphragm, right? So we'll just say two slips from. Obviously, it has to be the back of xiphoid process, right? It cannot be front because front it will become anti-abdominal wall. So back xiphoid process, right? Obviously, this would be small. So done. Regarding the coastal part, lower six, that is rib number 7 to 12, right? These are the ribs which will be taking part. Rib 7 to 12. Obviously, not only the ribs plus cartilages and plus transverse abdominis. All of them, they will be forming the coastal part. So all those ribs which are over here, right? So they will be forming this. This is the reason that actually the diaphragm is pretty high, right? Diaphragm is pretty high. And that was the reason that when we were taking those sections in CT scan, we were watching lungs and the liver together, right? With in between the pleura. Because here are the lungs, here would be the liver, but the diaphragm is actually, it is like this, right? So that's why in a cross section, both the structures, they come. Still, don't worry, right? We'll have still better view. This is super interesting, lumbar part, right? Lumbar part. And that's where we have to really understand that how will it really form. See, in lumbar, divide it into two parts. One is the arch, right? So how exactly the arch is? Say this one is the vertebra, right? And this is L1, the transverse process. Right? And over here, there is rib number 12, right? And now we are drawing only on one side. Same thing would happen on the opposite side. So one portion, let me just, yeah, one portion, this one, right? Obviously, this is medial, and this one, the lateral. So similarly, it would be like this and like this on the opposite side. And in between, there would be something, right? This is like whole diaphragm. So what this portion is called as, this portion, lumbo-costal, because from lumbar vertebra and costal, that is ribs. So this is lumbo-costal arch, right? That makes sense. Two components, this is the medial component and the lateral component. Fair enough. From the shape, they are arc-like, so we'll call them arcuate, right? We'll call them arcuate. Arcuate. Ligamentous structure, so let's call it ligaments. So this is like medial arcuate ligament and the lateral arcuate ligament. Collectively, they are forming lumbo-costal arch. Simple, right? Now, where exactly it is? Transverse process. So this will start from the body of L1 and it will continue till the transverse process of L1. So that's the medial part. And the lateral part, it will start from the transverse process and will go all the way up to the rib number 12. So that's how this entire dome, chhatri, right, that is formed. Okay. In between, I said that there are handles. They are called as crus. They are called as crus. Two parts, right and the left. Now, when the diaphragm contracts, right, these crus they will be handling it. So right crus, someone who is doing constantly exercise, right, obviously those muscles will be powerful. And on the right side, there is a big boss. Liver is sitting. So what? Right cross would say, I have to work because with every breathe, I have to pull the diaphragm down. So that's why right becomes stronger, right? From khate pite ghar, right? So he becomes larger and stronger, larger and stronger because he has to work against the liver. Left, he is like Sida Sada, right? At the same time, you say, right, he has to work more. So he is attached with three vertebrae. So L1, L2, L3, right? That's how it is attached. L1, he'll say, I don't have to work more. So 2 is enough. L1, L2. So that's how it is attached. So that's the reason left is smaller. Smaller. Yeah. Fine. Okay. Let's see this thing over here. Watch for that all the way, right? We'll just touch only that area which we have learnt, not all other things. That is, we'll not talk about this is right vagus and aorta. It would be like just telling you, but say you are smart enough to read the things. So we'll not talk about it. Just one simple. Inferior vena cava, keep an eye on esophagus and keep an eye on aorta. Just one thing, that this esophagus, right, it is in between inferior vena cava and aorta. Bus, that's it. That's the only thing which you keep in mind. Rest, what we talked about. We talked about lateral arcuate ligament. Yes, we know that now. This is good, right? So I'll put a dot on it. We know that. This is lateral arcuate ligament. So then there was medial arcuate ligament. Very good, right? And if we combine both of them, so that was the lumbo-costal arch, right? So that was our lumbo-costal arch. So this part is good. Same thing on the opposite side. In between it is It is what? This is median arcuate ligament, right? This is median arcuate ligament. Fine. So that is the thing, median arcuate ligament. Regarding this, as we said, that the right crus of diaphragm, and this one is the left crus of diaphragm. So they both are right and left crus. We are not touching any of the other things like greater splanchnic, right? Lesser splanchnic, subcostal, everything would come. Yeah, sympathetic plexus, we remember, right? We can just give a smile to this sympathetic plexus because it is like that pearl necklace, right? All those, and we remember it as we talked about it yesterday. Rest, we will not talk. Okay, don't worry, right? Rest of the structures would also be coming. So we talked about medial arcuate ligament and the lateral arcuate ligament, right? Now for the medial arcuate ligament on the left side, so when they really go, right, on the left side and on the right side, they will be associated with psoas major fascia, right? Today we'll be talking a bit more about this and his quadratus lumborum, right? We'll see these. But not the muscle. Right now, we are talking about the fascia. Because these muscles, they are covered by fascia. And it is this fascia, right, which will be in association with the crus of the diaphragms, right? So makes sense that when the crus is over here, and then L1, L2, L3, L4, L5, right? It is that psoas which is going over here. So obviously the fascia which will be covering over it, right? It would be gracefully in association with the crus. True? Right? And same thing would happen with quadratus lumborum. So for the quad, lumborum and the psoas major will actually draw, right? When we'll draw, it will become crystal clear that what exactly are we talking about. Okay. So for the right crus, now we are focusing on once again back to our diaphragm. So this is L1, L2, L3. Anterolateral aspect, anterior and the lateral aspect. So this is the anterior and this one would be the lateral, right? That's where the this right crus is attached. That's where the right crus is attached. What about the left crus? Is smaller, so L1 again anterolateral, right? And that's it. That's the left crus. Here it is, right? And you know why it is this right is from khate pite ghar, right? You know that. And in between, say in between, that is central tendon. That is central tendon, right? So it would be actually I should write it like, because central tendon is a bigger one, I should write it like say median, right? Because over here and here, this was medial, this was lateral arcuate ligament. Now it makes sense. So this one would be median, this would be medial, and this one would be lateral arcuate ligament. All three are arcuate. In fact, five, right? From here and here. So this would be the medial, and this is lateral. So that's how entire system is formed. Median is someone which is absolutely in the center. So here it is. Those crusts, right? Now, when it is taken in the form of that section, right? See, this is the central tendon. Just, yeah, this is the central tendon. That's the left dome and the right dome, right? This is where the liver would be there, right? So that's why this would be the wider. This would be wider, bigger, stronger, right? And this one would be obviously narrow and the smaller. True. Over here, that's where the heart would be sitting, right? So that is the pericardial area, pericardium. And this one, this region is abdomen, right? That's thorax. So it means there would be lots and lots of structure which will be passing out and in through this area, right? That is what we need to understand. Otherwise, this is clear, right? So this central portion, that is the central tendon, right? That's the central tendon, and that crus which is joining, right? That's what we saw in the form of, say, median arcuate ligament. We'll make it still more clear now. See, when we really watch it like this, so this is anterior, this is anterior, right? That's posterior, as if you are sitting into the abdomen and you are watching it. So this will be left. Oh, it is written over here, right? Left and right. So all the fibers, they are going like this. They are going towards the center, right? And then they decuss it. Decussation means like this. That's what is called as the decussation. Decussation. So this decussation actually gives strength, right? So all of them, so this central point, that's where everyone would come and decuss it, right? So this central portion, this one, that is tendinous, and that's what it is called as the central tendon, right? Of that entire roof, that is central tendon. And then these muscular parts, see, these are the muscular parts, right? They are the crus. They will actually be pulling because they are muscular, right? So they can contract. They will be having nerve supply, so the motor supply, so they contract and they move. Fair enough, right? Just in this much is to be understood. Now comes this part, right? The controversial part. We start with the easiest portion first. This is L1. This is L1. And say you can see that this is white. In between there is a soft area, this one, which is called as the nucleus pulposus. So that means we are not watching the vertebra. This is L1 disc, right? So this central portion is soft, pulpy. So that is L1. From L1, immediately the muscles which come out, right, classically, they are none other, but they are psoas major. See, that's the muscle, right? So this one is psoas. Oh, wait. We cannot write it here because then I won't be able to show you all the structures. Yeah. So that is psoas major. As I have explained many a times, follow the order. Always follow the order, right? If you follow the order, then very soon you'll be able to see all the structures 1, 2, 3, 4, 5, 6. You'll not miss it. If you try to go randomly, it becomes difficult. So here is L1 disc. Yes. Then psoas major on both the sides. So this is correct. This is fine. What is this? Well, just behind the vertebra, what it can be, right? It is the spinal cord. So over here in L1 it would be cauda equina. right? Cauda equina. That punch-like structure, right? Cauda equina actually means ghode ki punch, right? So it is that spinal cord, right? When finally it is into the form of those final fibers, which we are later on dispersing onto the respective areas. Okay, three openings, as I said, we need to see, right? One, a big one, right? Big one. Without any trouble, instantly you will say that yes, it is inferior vena cava. Good. And then there is a strong opening, right? This one, right? This is our dear aorta. And we said that in between inferior vena cava and our aorta, we do have this structure. Wait. Let me zoom it and you will appreciate. Do you see? Do you see this? See this opening and see how the mucosal folds they are seen, right? I'll erase it, but just for the representation, right? And if you say, see now, right? Say in case of vessels, there are no such mucosal folds. Over here, you should be able to see those mucosal folds, right? They are like this. So now you know it. So this one would be esophagus, this would be inferior vena cava, and in between is the big one, aorta. So now unzooming it, back to original. The blood vessels, right? The blood vessels which will be emerging from the aorta, the first vessel. If you remember way back, we talked about that they are inferior phrenic arteries, correct? Very beginning, we talked about it. Inferior phrenic arteries. Here is the darshan of inferior phrenic arteries. Say these. This is inferior phrenic arteries, right? So diaphragm would say कि इतना तो हक बनता ही है, right? When it is allowing the aorta to pass through it, so it will say कि okay, give me those some blood, and here it is. Here it is. See, this is also these vessels, right? This one is also inferior phrenic. Now, as we have drawn it, it will give you the idea that that the dome is like this, aorta is coming out, and then it is giving the branches, right, left, right, and it is supplying that underneath. And over here, this one, right, it is small one. It is small one, black color. This is a small one, and this is a big area, right, big one. What are they? They are crus, right? They are crus. So this is left crus, and this one is the right crus, right crus. So we know these major parts. Just if I remove everything whatsoever I have drawn, just a view, can you appreciate something like this? That say this area, right? This area, this one, right? This one. That is quite a muscular area, and in between this portion, right? It is pretty wide. That is the difference, right? Undo. See the muscular area and the tendinous area. So that's the central tendon. That's the central tendon. And it is this central tendon who is giving way for inferior vena cava, esophagus, etc. Aorta, aorta is just near to that vertebra, right? So that would be the reason that aorta is close to that vertebra. So that's why whatever those central tendon is doing, aorta is untouched. So that's why there is no change in the caliber of the aorta. Harsh, you are telling about this image. I'm sorry, I read your message bit late, but you are telling about this particular image or previous one. I'll continue teaching this image, but just let me know, right? In case if you are talking about this, so this is so quite easy. The vertebra itself is telling that this is posterior, correct? And this is anterior. That's anterior. Right and left, so they are easy. Okay, so that's it. Two very superb thing to be watched in this because they are seen so good. That's why I thought of showing you. I have to zoom it according to lumbar part. This image, say at the level it is like we are sitting in abdomen, right? And we remove all the organs and then we watch up. So it is at the level of lumbar one, right? Lumbar one. So say, just a minute. Here is the lumbar one, right? Very, I'm drawing very crudely because these are the transverse process, but this is how the diaphragm is, right? So when the diaphragm is like this, we remove all the organs, all the abdominal contents, right? And then we watch here, right? So that's what we are watching in this particular image. This is how we are, right, at the level of lumbar. Because yes, there will be other vertebrae, right, as we go down, but this is like we are just taking a section that all these things they are occurring at this level of L1, L1 disc, right? So L1 vertebra, and this is the disc. Okay, one more thing in this, as I said that I just wanted to show you something and I have to zoom it. Can you appreciate this and this? Right. Look at it. In fact, this. Can you appreciate this and this? Right. Such a trivial small markings, but they are one of the trickiest thing. This one is a zygous vein, and this one is hemiazygous. And that's the reason I said that you should have a cup of coffee today because we'll be discussing this azygous and hemizygous. Though it will take just 5 minutes, but we'll actually draw and we'll see that how the entire inferior vena cava is connected to superior vena cava, how those anastomosis develop, what really happens to hemiazygous, accessory hemiazygous, and everything. Right? We'll complete the entire circulation. So just do remember that they are so close, right? They are so close because that's where they will be piercing and they'll be going into the thorax, right? These are veins. So veins will be coming from the lower end. That means this is the ilaka of inferior vena cava. Thorax is the ilaka of superior vena cava, right? So that's where these two, they will be entering into the system. Uh, oh, okay. Confused between right and left. Okay, okay, okay. See. You remember inferior vena cava, right? We said that inferior vena cava is on the right side, right? And aorta is slightly on the left side. True? Because aorta, it emerges from the, right, if from the left ventricle, it takes turn and then plane remains the same, right? Plane remains the same. It takes turn and then from anterior to it goes towards posterior and then straight away dips in. So it means it is going more towards the left side. So that's where it is on the left side. Which one? This is confusing. Okay, don't confuse much, right? Just remember this one should be clear. Inferior vena cava. Aorta is always near because this is exactly like a section, CT scan section. You must have, I have shown you so many CT scans, right? And every time, just near the vertebra, it is aorta, all big one, right? So You will not face any problem for this, right? That's the second point. And esophagus, that is because of its mucosal structure. How to integrate names and structures? See, names, so they are a bit easy. We'll keep on integrating as we proceed. Right now, I am not adding anything about all these muscles, the muscles which are on the posterior aspect, right? All those things we are right now not added. In fact, if you can see even the cut sections of all those ribs, this is the costal margin, right? This is costal margin, right? See how nicely all those cut ribs they are seen. See, but don't worry much about it, right now just think it like as such. I don't think this is as complex. Say that's the diaphragm, right? And this diaphragm, this is like those crusts. This is a complete dome, right? This is like a complete dome, and this entire dome is pulled by these handles, so they are called as the crusts, right? And they are muscular, so that means when we'll be giving that current to them, right, via those electric wires, I mean nerves, right, so they will contract, they will pull the whole system down. But here would be the liver, right? So all the abdominal organs will be brought down because from top that diaphragm is pushing, so that vertical distance is increased in the thorax so that lungs get more space. That's what really happens during inspiration, right? Sure, I'll teach head and neck. Why to worry? Definitely. Okay. So, and in case if there is any doubt, right, don't worry. We'll watch it and we'll solve it. But say by the time you'll finish the whole thing, so many doubts would be clarified. Now see, these are the major openings, right? Major openings in the diaphragm. First thing first, right? The vena cava opening. We saw that vena cava opening, right? And we understood that it dilates. Yes, because then and then there would be better venous return. When there is better venous return, so that means that blood will go into the lungs and is ready for our inspired air, right? For the carbon dioxide and oxygen transfer. So that is vena cava, right? Level T8, T8, T10, T12. Quite musical, right? 8, 10, 12, right? Gap of 1. This is quadrilateral, right? Well, these shapes they are right in natural way. So yes, I would appreciate that this elliptical, that is good, because that's how the esophagus would be, right? Because esophagus is bit compressible. And aorta, yes, a rounded structure because it is tougher one, right? So it is well rounded. And vena cava is a big one. So yes, you can say quadrilateral, but actually it takes any of the shape. Okay, so vena cava, this is what I'm interested in. Vena cava, when it is pulled, right, it dilates, right? It dilates, that opening dilates. For the esophagus who is sitting right over there, it leads to constriction because of an angle. So when it pulls, it leads to that valve type effect. Aorta, aortic opening is close to the vertebra. So that's why that opening, this aortic opening, it is also called as the osteoaponeurotic. That is osseous, bone and aponeurosis, right? So this is osteoaponeurotic. This means whatever the diaphragmatic position is, right, whether it is contracting, moving, there is no change, right? There is not much of the difference to the aorta. Esophagus, yes, it lies in the muscular part, so that's why there is like effect. And this vena cava, as it lies itself into the central tendon, right? That is what we saw, that central piece. So it lies in central tendon, central tendon. Okay. See, here all those major openings, but we understand one. Inferior vena cava, that's the aorta, right? We'll write it number 3. Aorta, which is near the vertebra, the level of T12. This is vena cava, that is at the level of T8. And in between is the esophagus, right? Esophageal opening, that is at T12. So this one is T8, this one is T10, and that level, right? Over here, this level is T12. Right? Just 8, 10, 12. 8, 10, 12. Right? These are the levels. Okay. There would be some small openings, right? Now, I'm not writing all the small openings, right? Why? We understand the zygos and hemiazygos. All right. If not, no worries. We'll be discussing it today. We know about sympathetic chain. Yes, we very well know, right? In the last session, we talked about it, that beautiful pearl necklace, right? Sympathetic chain. So this is the known, right? Subcostal nerve, well, it makes sense. Subcostal nerve and vessels, right? Subcostal, last one. Nerve and veins and vessels and arteries. Yes, it is okay, right? Easy to understand. Then there would be some other vessels like superior epigastric vessels, musculophrenic vessels. Don't worry much about it. Remember about this part, which we shall be discussing in future, but it will be carrying a big value, and that is splanchnic nerves. And there would be two, greater splanchnic and the lesser splanchnic. Right? Very soon, both these nerves, they will be on our radar, right? We'll be discussing it. So right now, we are not talking about all those superior epigastric vessels or musculophrenic vessels. They are there, right? We'll see. Important is those major ones. Okay. Now something which will clarify all the doubts. That is about the relations. Superiorly, right? Superiorly. What would be there? That's the diaphragm. We are talking about the diaphragm. So superiorly, there would be only two things. One would be the pleura, which will be covering the lungs, and second is pericardium, that is in the central portion, which will be covering the heart. Done, right? What about the inferior? Everything. Everything in the abdomen, right? So first, if we are talking about the covering, so we cannot eliminate peritoneum. After that, whatever comes in your mind, keep writing, like say liver, then say stomach. Obviously this here we have to be more specific, that is the fundus of stomach. And this, in fundus of stomach, there would be air, right? So when you'll be taking that plain x-ray chest, right, so then you'll see that air, right, which can be seen very clearly. So that is what so we just write x-ray, right? So that we keep in our mind that whenever we'll see the x-ray, we'll see this. So liver, stomach, that is the fundus of stomach. Then all the topics which we talked about, spleen, kidneys, adrenals, right? They all are over there. True? So these are the inferior relations. Now comes the nerve supply. In nerve supply, now in the next 2-3 minutes, they will be vital. Nerve supply, remember, it is motor and sensory. Those muscles, they basically, it is muscle. So there is only one nerve, and that is phrenic nerve. Phrenic nerve. This nerve, root value C3, C4, C5, so high, coming all the way from the top. Yes, because in developmentally, the diaphragm, it develops in neck, and then it comes down, right? So that's why it is carrying these nerves from its beginning, right? But the point is, this is the only motor nerve, this is the only sahara of diaphragm, only one. If anything happens to phrenic nerve, khatam, that diaphragm will be paralyzed, right? And then diaphragm will start working ulta. Normally when we breathe in, right, so in inspiration it pulls, when we breathe out it comes up, and in paralysis, that is phrenic nerve palsy, it becomes paradoxical. That means it becomes ulta. It works in the reverse way. So this is the phrenic nerve, right, which is a motor nerve. Very important. How about sensory? For sensory, the sensory has got so many Saharas. The central portion, right, it is divided into central and peripheral. So this is the central portion, and this central portion, that is taken care by phrenic nerve. So phrenic nerve will say, okay, central portion of the sensory. What about the periphery? This peripheral part, right? Peripheral part, that is by T7 to T12, right? Thoracic 7 to T12 spinal nerves. So that is taken care by them. So that is periphery. Periphery. Now this phrenic nerve, now comes the crucial point. This phrenic nerve will be playing a major role in plexus. Now see, I am preparing you for that discussion when I said that yes, we'll be talking about all the plexuses. We talked about sympathetic plexus, sympathetic, right? Sympathetic chain. So that sympathetic chain, as from the hypothalamus, right? Things were coming, and then they started giving all those twigs to the spinal nucleus, because it is still into the spinal cord, and from there they start coming out, and we said that there will be celiac plexus, superior mesenteric plexus, and inferior mesenteric plexus, and some of the fibers will bypass and they will reach to over that lovely adrenals, right? And that's how the systems they were going on. This phrenic nerve, right, this phrenic nerve will give branch to celiac plexus, right? It will give a branch to celiac plexus, right? Just this much, celiac plexus. Also, the phrenic nerve will also be giving sensory supply. Let's see, it is giving sensory supply to that central portion of the diaphragm, but it will give sensory supply to pleura, right? Pericardium, right? And all these, right, all these, that's the reason for that referred pain. That's the reason for referred pain. We'll come to that. But say it is not only giving, say, sensory to the central portion, but also to pleura, pericardium, right, diaphragmatic, mediastinal, right, fibrous, serous, all of them. Okay, just keep in mind for the celiac plexus. Okay. Now see, what would be the actions? One, prime inspiration, because inspiration is an active process. Expiration, nothing is needed. In inspiration, to increase vertical diameter of thoracic cavity, so diaphragm descends, right? So that's, then when the diaphragm descends, then and then there would be increase in the vertical diameter or the vertical distance, so that lungs they get more space, right? How much is it? When it is a quiet inspiration, when we don't know it is happening, so that movement is just 1.5 centimeters, right? Just that much. But when it is forceful, right, when it is forceful, so then diaphragm is pushed still more, and that's where it is almost 6 to 10 centimeters. So that's where it is really powerful. So this is, one is inspiration. Second is for all the expulsive acts, right? All the expulsive acts, when things are to be pushed out of the body, right? Whether it is air, that is sneezing, coughing, right? They are like expulsive act. Even when you are spreading happiness, right? So that is laughing, right? Even crying. And crying is not necessary because of sadness, it could be khushi ke aansu, right? So then all those like vomiting, micturition, defecation, parturition, that is baby delivery, right? All those, they are called as collectively expulsive acts. So that's where diaphragm will be coming into picture to increase the intra-abdominal pressure. The third thing, it is, we just talked about it, the sphincteric action. That esophagus which was coming, right? Those muscles, they are at an angle, so they will actually compress it. So that is like a constriction effect, right? So that is at the lower end of esophagus. True. Now just one simple thing which is of the clinical importance. We'll draw one thick line, one thin line, and one dotted line. When the person is supine, this is the position of diaphragm. So diaphragm goes high, right? When the person is standing, I'll tell you the reasons also, but this is necessary to know. Right? So when the person is standing, it is in between. But it is lowest when the person is sitting. Reflexly, if you find someone that someone is breathless, तो कहते हैं अच्छा अच्छा बैठ जाओ, right? Just sit down. Why? Because when the person sits down, his diaphragm would be at its lowest level, so lungs will be automatically getting more space, right? Now the reasons. In the lowest, when you are sitting, muscles are relaxed. Muscles are relaxed because entire pressure and everything, the support, it is the hip muscles which are taking care of. So rest of the muscles, they are relaxed. As they are relaxed, diaphragm will settle down, right? So thus giving more space. So that's where there is better respiratory reserves, right? That is available, better efficiency. When it is standing, why it should be like that? Because when the person is standing, those abdominal muscles, they contract, right? So anterior abdominal muscles, they contract. When they contract, they will raise intra-abdominal pressure, right? They'll raise intra-abdominal pressure. When that pressure is increased, it will push the diaphragm up, right? It will push the diaphragm up. So that's the second part. But then about the supine part, when the person is lying, why diaphragm goes all the way? Because here, when the person is supine, two things happen. In supine position, it is like those abdominal viscera, they push, right? So viscera, that is abdominal viscera, they push the abdomen high, right? And that's how it goes at the highest level. So this is needed, that is in case, say if someone is having asthma, breathing problem, right? So if he's lying down, he'll not be comfortable, right? So it is this position, right? It is this position. That's why you in bed you require that elevated thing. Or if someone is at home, you just put few takyas, right? And then can breathe properly. Yes, actually, this thing, I remember that that during COVID, I got right lung collapse. Yeah, and the oxygen saturation and everything dropped, and trust me, this is like, as I said previously, this is like second life, right? Simply because of you guys. So at that point the breathlessness was bad, right? It was impossible to sleep. So that's why I said put all those takiyas and you remain into that position for the entire night, so that at least you can breathe. So that's why so important. Okay. Now this is a small boring theory, drawing it just for the sake of that. Yes, few words should be known to you. When we'll be discussing actual embryology, at that point it will make the complete sense, right? So just know three words, only three words, not more, for the embryology, because they are the keywords. So this is what central tendon, right? This central one. So this is central tendon. This central tendon will develop from what's called as the septum transversum. Transversum. Because of lack of time, we can't discuss this thing. Otherwise, we'll spend another 2 hours only for the embryology part, right? And this portion, just remember this much. That is dorsal mesentery of esophagus. That is from where it develops. So from the dorsal mesentery of esophagus, the entire embryology, it is actually very dynamic, right? Absolutely superb. On the right side, it is from the, because see, this is only for the left side. For the right side, that is what is called as the pleuroperitoneal membrane, right? So it is what is called as the pleuroperitoneal membrane. But that's it. These are the words which you just have to keep in mind. Pleuroperitoneal membrane, right? Septum, transversum. This is more important, right? Just remember it. And this one is dorsal mesentery of esophagus. That's it. No doubt there is this lateral thoracic wall that would also contribute, right? Partly, but that's okay. This much is enough. So clinically, one what is called as the hiccup. Hiccups. So that's where the diaphragm contracts. This is what is called as the spasmodic. It is called as the spasmodic contraction. Contraction of diaphragm. Now it could be two way. One is what is called as the peripheral. So basically there has to be some irritation, right? It is the local irritation, and that can lead to hiccup. Or it could be central. Central means straight away somehow the hiccup center in medulla, that is associated. So right, something which is related to brain, right? That is where the center, right? That center is affected. Say for example in uremia, it happens. So either the local is more common. Second thing which we need to know about is the shoulder tip pain. Classical shoulder tip pain. Why the shoulder tip pain? That is whenever there is irritation of the diaphragm, right? Say we saw that phrenic nerve, which is sensory, right? C3, C4, C5, that is the root value. But there is one more, right? That is the supraclavicular nerve, right? And when we were talking about upper limb, when we during the discussion into that, so then this supraclavicular nerve which supplies the shoulder, right? This supraclavicular nerve that is also having the root value of C3, C4, C5. So actually, whenever there is irritation, right, there is irritation uh, of diaphragm. So then phrenic nerve becomes, say, it comes in action, goes to C3, C4, C5, but then as it is telling that yes, there is some irritation, those sensations, they will travel all the way to the supraclavicular also, and thus there is a confusion, and that leads to, say, shoulder tip pain, classical shoulder tip pain, right? The third is paradoxical movement, right? And we talked about it, that what is paradoxical movement. Paradoxical movement of diaphragm, right? Everything we are talking about is diaphragm. It is due to that phrenic nerve palsy, right? Phrenic nerve is damaged, so that leads to paradoxical movement. Paradoxical means reverse of normal. Then if, say, this is a muscle, right? So these are strong muscles. Now if these muscles are weak, then sometimes that umbrella, it becomes ulta, right? It becomes like this, right? So if the muscles are weak, so congenitally, if there are weak, or there are less muscular tissue, it becomes, diaphragm becomes ulta, and that is what is called as the eventration, right? Eventration. So those, you can say, muscular or the muscle component is less or weak. So that leads to that. What about pronal position? In prone position, it is still a bigger advantage, but the reason is different, right? Because that gives the maximum advantage for the breathing. Okay, for the diaphragmatic hernia, right, the congenital and acquired. Congenital and acquired. And in acquired, we have one, what is called as the traumatic. Because see, whenever there is trauma, accidental or surgery, right? So that is a potential weakness. And through that, hernia, we know that when the abdominal contents, they start moving on to the other chamber. So when it tries to go up, now here it will be going via diaphragm. So it is diaphragmatic hernia. Acquired means this is because of trauma, right? And as it leads to weakness. There would be another thing, what is called as the hiatus hernia. Hiatus hernia. Two types. One which is called as the rolling. We'll just see that. Rolling, and second is sliding. Now if we say rolling, this is congenital. Right? When we say sliding, this is acquired. Acquired means it is due to some potential weakness, either accidentally or it occurred because of some surgery. See this congenital hernias. That is what we see. The See this one. This is Morgagni foramen, right? Where is how we really look at it? This is more common on the left side, right? And this is the space which is between xiphoid process and the costal origin. So this is anterior, right? That is anterior. So this Morgagni foramen, it is between xiphoid process. This is between xiphoid and costal margin. The second one, right, which is this Bogdalek foramen. Again, say this one is actually the commonest. Is the commonest, right? Because in Morgagni foramen, sometimes there are no symptoms, no pain, nothing. Over here, it is because of this pleura and peritoneal, right? So this is the pleura peritoneal hiatus. Hiatus means this is the space. This is pleuroperitoneal hiatus. So through that, when it tries to, right? If it occurs, this is a serious problem, right? If it occurs, it is a serious problem, requires immediate surgery. Reason behind it is that this is like a congenital thing, right? We are talking about congenital, right? Congenital hernias. Not very difficult to understand. It is a natural defect. If there is defect abdominal organs, right, all those abdominal viscera, they will be pushed into the thorax. Now in thorax, lung is there. Lungs would say no, there is no space. But when those viscera they are pushed, it will lead to acute respiratory distress syndrome. In other words, respiratory distress. When there is respiratory distress, that would lead to death. So that's why it has to be operated immediately, right? To be operated ASAP, as soon as possible. And that's why this thing would occur in those infants, kids, right? Then for the central one, this is the third one, this is a rare one, right? Because it's a tough structure, so rarely it occurs. So that is just about the congenital part. And here it is. Those points which you should know. 1 and 2. This one, they both are types of hiatus hernia, right? And this one is rolling. This is congenital. So no problems with esophagus, no problems with stomach. That is going good. But because of that defect, the defect which is over here, the part of stomach, it rolls up. And that is what is called as the rolling. This is congenital. Some surgery was done and this natural opening that has been weakened. So that's why this is acquired, right? Maybe because of surgery, maybe because of some increased pressure, maybe because of obesity, any of those things, right? So that is what is called as the sliding. That's where the obesity, reflux, constant coughing, etc., right? They will come into picture. So that's the difference between rolling and sliding. Okay. Now we are talking about posterior abdominal wall. Now, in posterior abdominal wall, actually, it is not that complicated because we'll be dealing with aorta, which you know most of it, right? We'll be talking about inferior vena cava, worth discussing. Then we'll spend some time on a zygos and hemiazygos because it would be like a link between superior vena cava and inferior vena cava. Then we'll talk about those lymph nodes as there is a very beautiful pattern in that. And finally, the muscles, which you already know, right? But as promised, we'll actually draw them, right? We'll draw them. And as I said, that I'll be preparing you for that session where we'll be discussing all the plexuses. So that's where the nerves would come into picture, right? So all those lumbar plexus and sympathetic plexus, that is autonomic nervous systems, etc., right? They will come into picture. But that we would be studying separately. So let's start with our first image. Now you need to orient yourself very properly because this is showing lots of structure, right? There are only few pages, but they will be showing you lots and lots of structure. At the same time, the complete clarity. We start with something which is already known to us. So here is kidney. right? This is kidney, left, correct? Left kidney. If that's the kidney, it means on top of it, we have got suprarenal gland. So that's the left suprarenal gland. Okay. If that's the suprarenal gland, then we know the pattern. That suprarenal gland will be sending one vein to left renal vein, right? Because you know the pattern, right? You know it. This is the renal vein, then that's the suprarenal vein, and then it will go like this, right? So here it is. If that one, so can you see very nicely this one, right? That is suprarenal vein. It is going into what? It has to go into the renal vein. So this big one, right? That's the left renal vein. That's the left renal vein. So far, so good. Arteries, where are arteries? Arteries are always behind. So this behind these structures, these tougher structures which we are watching, right? These are the behind. So they are, see this one, right? It is behind. This behind, right? They are renal arteries. All are left, so that's why I'm not writing left, 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 right? All are left. So then where is that ureter? Always from the lower end. So here it is. That is the ureter. Correct. There was one more vessel which was landing into the renal vein. So this is the renal vein, right? This one is renal vein. So in that case, this long vein, right, going all the way down. So it has to be gonadal, correct? That is the gonadal vein. So that part is done. Superficial structures, right? See, there is one big one, very tortuous, and it is going where? See, it is going and then going towards the lateral aspect, and see the structure. It is going into a structure which is like arranged like this. This is pancreas, right? That is pancreas. And in the substance of pancreas, who is going is nothing but splenic vein. Once we have got splenic vein, then we are big boss, right? We know this is splenic vein. So then inferior mesenteric vein will be joining it. Where is it? This one, right? See the bigger one, inferior mesenteric vein. So this inferior mesenteric vein and splenic vein, they both would join, and then this superior mesenteric vein will contribute, and both of them, they will form that portal vein and all the journey towards the liver, right? So done. Okay, so this much is clear. In order to see this thing, because as such, so everything is covered by the gungat of that greater omentum, so we have to lift it. So here it is the greater omentum, right? So that is okay, just telling. So that is greater omentum. So we know now renal vein, renal artery, left suprarenal vein, left suprarenal gland, kidney, ureter, gonadal vessels, inferior mesenteric vein, splenic vein, pancreas. I think this much is good. Our favorite muscle, right? Our favorite muscle. That is, you know that. Psoas major. Because psoas major is providing the floor on which everything is spread across, right? By the way, there is one very nice thing I just realized. I'm erasing it and even erasing this, because two vessels, they are two nerves. They are seen nicely, so nicely. See, iliohypogastric and ilioinguinal. Here it is. This one, and this one, second. Right? This is ilio, because normally at times it becomes difficult, but over here very nicely seen. So iliohypogastric, the lateral most iliohypogastric nerve, and that one is ilioinguinal nerve. Ilioinguinal nerve. Right? Now we can write over here. This is psoas major. As such, know him. And then that was the ureter. This one was ureter, and this one is that gonadal vein. Enough for this image, right? Quite clear. And yes, all those are back muscles, this, that, everything. That's enough. That's enough. One good thing in this entire images, that see, it clarified all those, and it was a sort of revision for those veins, etc. Right? So it will help us further. Okay. Now let's start with the very easy topic, abdominal aorta. Now this would be acting like a filler. Whatever we have discussed till this point, it is like it will just fill up everything. Whatever is left out, right, it will be completely clearing those things. Starts with T12 lower border, right? That's where abdominal aorta starts. And at the level of L4, it splits, right, into right and left common iliac artery, that but this thing is occurring on the left hand side, right, from the midline, so about half inch on the left side. So that's what we saw, right? During that major opening, it was on the left hand side. So this is common iliac, right and left, right and left. For the relations, anteriorly, celiac plexus, right? It makes sense because all these plexuses we talked about yesterday, celiac plexus, superior mesenteric plexus, and the inferior mesenteric plexus, they are associated with their respective vessels. So this is celiac plexus. Celiac plexus, as the celiac trunk is anteriorly, so celiac plexus. There would be one more, that is aortic plexus, right? So that would also be in its anterior part. And rest we draw and we'll come to know, right? Say that's our D1, D2, and D3 duodenum, right? And then this was all the way pancreas. Where is aorta? Aorta is absolutely behind all of them, and then it comes out, right? Aorta is behind all of them. So it means all these structures, they are in front, right? So D3, the third part of duodenum, right? And the pancreas, right? Pancreas, body of pancreas. So this part was not very tough. What about the posterior? It is still easier, right? Because there is nothing in the posterior. Posteriorly, it is just all those L1 to L4 vertebrae, and every vertebra, this is one vertebra, this is second vertebra, and these are the anterior longitudinal ligament. So in other words, whatsoever is attached with that vertebra, so we can just write that is anterior longitudinal ligament, just for the sake of writing, that's okay, right? On the right side, what we'll be getting on the right side and the left side, that's interesting. So here is our aorta. It is in between, right? On the right side of the aorta, first we'll see, and that would be IVC, inferior vena cava, because inferior vena cava is right. And that's the reason that right renal vein was short and left renal vein was so long, because it has to travel all the way, right? So that is inferior vena cava. Then right crus, right crus, right? We just talked about it. Right crus of diaphragm, right? And add one more thing, that is cisterna chyli. That is for the lymphatics. On the left hand side, yes, there would be left crus. So left crus. Left crus just L1, L2, right? This one was L1, L2, L3, just to remember, right? What else? Pancreas, right? Big one. And the D4, the fourth part, right? That fourth part. So that is obviously on the left hand side. Not very complicated. Again, in this figure, we'll just watch only the branches, right? And this is for absolute clarity. Branches of aorta. See how easy they are. One, inferior phrenic, right? So done. This we know. Inferior phrenic, left inferior phrenic, right inferior phrenic. Yes, we know that, right? Then what else? The celiac trunk, right? Here it is, the celiac trunk, this one. So that's celiac trunk. Then superior mesenteric artery at the level of when the renal arteries are there. So superior mesenteric artery, left renal artery, right renal artery, right? That is also good. Fine. If that is superior mesenteric, where is the lower one? Here it is the inferior mesenteric. Very good. That is also known to us. It will divide into common iliac. So yes, that's so obvious. But in between, there is one which is called as the median sacral artery. This is this one, median sacral. Only one. So that's why it is not medial or lateral. It is just median, right? So that is median sacral artery. Good. These are the gonadal arteries, right? That's what we were watching. Left and right gonadal artery. For rest of them, right? For rest of them, we need to remember our adrenal, right? For the adrenal gland, right? We will just draw it off on one side. Say that adrenal gland was getting the supply. How? We drew aorta, right? Then from aorta, there goes the renal artery, right? So one from here, one directly, and one from that inferior phrenic, right? Over here. Yesterday we talked about it. True? So this is inferior phrenic, right? That is inferior phrenic. So inferior phrenic will be giving superior suprarenal artery, right? So we'll just write superior. Middle one, well, that is directly from the aorta. And this renal artery is giving that inferior suprarenal, because adrenals, they are richly supplied, right? They are richly supplied gland. So this is how they will go. And so that's why we need to see a very specific artery, and that is middle. Where is it? Here it is. See, this is middle suprarenal artery, right? This one is middle suprarenal, and this is on the opposite side. These are very specific because they will be giving blood to the adrenals. Regarding superior suprarenal, inferior suprarenal, they are separate. All right, that's it. We just see this much in it. Okay. Now, if you really want to go for, say, systematically, how it is described in the book, right? So it is like abdominal branches. So that is aorta, right? Aorta. So one is ventral and second is lateral. So ventral means they will be going anteriorly, right? And they are unbranched. So celiac trunk, right? Superior mesenteric artery and the inferior mesenteric artery, done. Bas, that's it, right? These are ventral. For the lateral, it means they will be on the right side and the left side. And we saw that inferior phrenic, right? Inferior phrenic. Now the inferior phrenic is our friend, right? Right from the beginning, we are talking about it. Then middle suprarenal. This is good. Middle suprarenal, because now this artery has become special, right? Then renal, and this renal will be going to kidney. Not only that, it will be giving a branch that is inferior suprarenal. Great. And the gonadal, that is testicular in male and ovarian in case of female, right? So this is done. Apart from this, see that's it. Abdominal aorta has only these many branches. On the posterior side, that is dorsally, right, just behind, there are lumbar lumbar arteries, right? These are four, right? And on both the sides, right? So I will just write right and left. And then there was one pooch like artery, and which we said median sacral, right? This one, this is what we are talking about, median sacral. So that's it. That is the last and final, that is the median, right? Median sacral, right? And it is unpaired, just one. It is only one. Done. And then we know it. What happens to aorta, right? No need to write. This is common iliac right and common iliac artery left, and then it divides into external and internal iliac and so forth, right? You know this. And yeah, this is at the level of L4. That's what is interesting to know, right? It divides at the level of L4. I know this is heavy. Topic is light. Now this is inferior vena cava. That's the favorite one. At the level of L5, common iliacs, they come and meet. Common iliac, not artery, now common iliac vein, left and right, they meet and they form this important IVC. It is at this level, L5, right? As it comes up. So regarding the relations, anteriorly, again, this is a posterior structure, right? So most important is that liver, right? Liver, that would be in front of it. Then D1, right? Portal vein will be in front. Because see, in the liver, on the posterior aspect, we were watching that inferior vena cava, in which those hepatic veins, they were draining, right? So pancreas, that is the pancreatic head, that is also anterior. Then D3, right, that is also anterior. So actually, if we really draw it, it is something like this, the aorta, right, it is, we'll draw it in blue, right? Aorta, I'm sorry, inferior vena cava, right, it goes something like this, right, like this. So that's why over here it is D1, right? Over here it is the head of pancreas, and this is D3. All of them, this is IVC, right? Because aorta was over here. Aorta was over here. So that's why in this case it was body of pancreas which was lying in front of it. D1 was almost over. So that's why only the D3 was in its anterior, right? Got it? What about the posterior part? All those easier things, right? Posterior part. Right crus, right? But in the posterior, there is right renal artery. That's what is interesting. That's what we were watching. Even the right celiac ganglion, right? Even the right adrenals. That's what we need to remember. Regarding its tributaries, who is coming and meeting? That is all pretty easy. So let's draw common iliacs, right? They come and they form IVC. Then from both the sides there are right renal veins. Then those gonadal veins, right? They will be joining, right? Then suprarenal vein, that suprarenal vein either it is draining here or but that is in the case of left. Wait. This is like we need to revise, though you know it. Here is the right suprarenal, this is the left suprarenal, and this one is, say, IVC, right? Here is the right, I'm sorry, left renal vein, and this left suprarenal will land into left suprarenal vein will land into left renal vein, correct? And then it goes into IVC. What about the right? Right goes directly into IVC. So that's why when we write tributaries, we need to be specific that it is the right suprarenal vein which goes directly into the IVC, not the left one. Left goes into the left renal vein. And right, so this is one. I'm not writing the name because you know that. So this is common iliac, right and left, right? Then this is like say 3 and 4, these are like renal veins, right? Then say this is over here, right? This one would be a right suprarenal vein. And most important, all those hepatic veins, right? All those hepatic veins, they will be landing into the inferior vena cava. Fine. So just for the reference, right? In case if anyone has got any confusion, so here is superior mesenteric, that is inferior mesenteric, right? It comes over here. It goes like this: superior mesenteric vein, inferior mesenteric vein lands into splenic vein. They form portal vein. It goes into the liver, right? Liver processes everything, comes out in the form of hepatic vein. It goes into the IVC and the system continues. That's why this is called as the porta cable, right? Porta cable system. That is porta, that means it is this portion, cable, that is this portion, right? That's how they are connected. Okay. Yes, in this case, one more thing enters, and that would be the hepatic artery. And this hepatic artery, yes, that's the aorta, and aorta, it was giving those inferior phrenic, right? From here, there was splenic artery. Then one more, so this was the celiac trunk. That celiac trunk, it gives splenic artery. Then there was left gastric, and then there was this hepatic, right? So that's how it really goes. Okay. Now I take you to the Zygos system. It'll take full 5-7 minutes, but it would be very fine if you draw along with me or just understand it. But yes, at a later stage, you try to draw by yourself also. It will be very beneficial because this Zygos system is the connectivity between superior vena cava and inferior vena cava. And it would make really good sense when we'll be talking about all those anastomosis and pathology, right? Okay, let's draw it in a very simple way. As we know that superior vena cava, right? So that is into the thorax. So how it would be formed? So it would be formed by this brachiocephalic trunk, correct? Brachiocephalic. So obviously from here it is the internal jugular vein would come. So this is on the right side, and then from the left side, right, this brachiocephalic. So this is right brachio, and this is the left brachiocephalic, and this one is internal jugular. So from internal jugular, from upper limb, right, the blood comes, and here is the formation of superior vena cava, right, and it will go into the right atrium. Now we change the color, right? This is inferior vena cava. That means we are talking about now abdomen. And it is formed by those common iliac veins, right? Common iliac vein. Now from common iliac, here starts the real azygos. From common iliac, there is one tributary. It is going up, and this is lumbar region, so we'll call it ascending lumbar, right? Ascending lumbar. Over here, we are into abdomen, right? So this is where even the renal veins are there, right? That's our superior vena cava, and these are the renal veins. So even they can take part. So in other words, it is the right ascending lumbar, a tributary from, it could be from renal vein, it could be from inferior vena cava, right? And that leads to form what is now going all the way up, and is landing into the superior vena cava. This is what really happens on the right side, right? So this one is what is called as the azygos vein. Now there would be lots and lots of all those subcostal and all those costal vessels, right? They will be over there, but we are not drawing it for the sake of simplicity, for the understanding. So that's what is called as the azygos vein. This is what happens on the right side. On the left side, things are different. Draw it like this. So over here, one and one. This is called as the accessory hemiazygos, right? So this is because the final destination is superior vena cava. So this is accessory hemiazygos. Hemi because it is dividing the whole thing into two parts. So this lower one is called as the hemiazygos, right? This one is hemiazygos. So upper one was called as the accessory hemiazygos. So this is hemiazygos. Same thing. Almost everything is like that only, right? Over here, there would be ascending lumbar, right? It is the ascending lumbar, right? Then some one tributary from say this renal vein or from the inferior vena cava, right? But the finally it is leading to formation of this hemiazygos. So this hemiazygos, it travels, it meets right sided azygos. This accessory hemiazygos that also lands into azygos vein. So all of them, they finally go into this azygos vein. Azygos goes into the superior vena cava, and it goes into the circulation. So say this is the thing. This is how this portion is that portion which is connecting superior vena cava and inferior vena cava system. Very vital. So you can say it like this is origin. This is from where the Zygos system starts, and the destination is over here onto the superior vena cava, right? So that's the journey. This system is called as azygos. Azygos literally means asymmetrical. So how appropriate, right? Azygos itself means asymmetrical. So it is asymmetrical, right? Very few areas of the body where things are so much asymmetrical. One more, that even from here also there would be few coastal vessels, right? Just for the understanding, but otherwise that's how things they really go. Now superior vena cava is in thorax, inferior vena cava that is into the abdomen, so that's how they really communicate, right? A beautiful association between all of them. Fair enough. Okay. uh in this, watch for two things: nodes, para-aortic lymph nodes, right? And the lateral aortic lymph nodes. Bus. Rest of the vessels and everything is, see, lateral aortic lymph nodes, and the, this is not para, this is pre-aortic lymph nodes. Sorry. See, for the lymph nodes, all of them, they will be landing finally into the aortic, right? So we have got the external iliac lymph nodes. They will go into common iliac lymph nodes, right? And for this external iliac, as the name suggests, they will be following external iliac arteries and veins, right? They follow those blood vessels. And yes, we have seen this external iliac into the lower. So they will be draining like inguinal region, right? Inguinal region, then inner thigh, right? Then urinary bladder, uterus, etc. Right? Very important. They will drain into the common iliac. From common iliac, it will go to these aortic lymph nodes. So when we talk about these aortic lymph nodes, they are, that's what we saw, right? They are like in two parts. So one is that pre-aortic, which we saw, and second is this lateral aortic. So now we see it makes sense. Here it is, right? That is lateral aortic and the pre-aortic. So this lateral aortic, they receive everything from common iliac nodes, and pre-aortic, they are receiving it from intestinal trunk, right? But this is important. That is from intestinal trunk, it comes over here. And what about lateral aortic? Lateral aortic, they are from common iliac, thigh, inguinal region, everywhere, right? So that is from where the lateral aortics will come. All of them, all of them will finally go into, that's what is called as the cisterna chyli. So this is the tube which will take the all lymphatics and will travel up. And this is cisterna, right? This is like a lymphatic sac, right? About 7 centimeters to 3 inches, and it forms, and finally it goes into the thoracic duct, and then into inferior vena, right? So How it happened? That the intestinal trunk, right? Over here, the lumbar trunk, right? That is from the lower limbs. This is from the intestines. They form and it goes up. That is into the thoracic duct and finally into IVC. This is how the cisterna chyli would be formed. Now the easier portion, these are the muscles, right? For the muscles, we have got psoas major, right? Psoas major, quadratus lumborum, iliacus. Iliacus is the cousin of psoas major, and the inguinal ligament, we know it well. Say for the psoas major. To understand this, just simple, right? Very simple. Just we draw T12, T12, L1, L2, L3, L4, L5. From all of them, right? So that's where the psoas major. From the adjacent vertebra, intervertebral disc, all the way it goes down, right? Also, it is not only from the body, also from the transverse process. But then, so that's the origin. What about the insertion? For insertion, we remember that it passes the hip joint, right? So this is greater trochanter, that was the neck, right? That was the head, and this is the lesser trochanter. That's the portion. That's the portion. So in collaboration with iliacus, right? All of them, this psoas is coming from the top, and that's where they land. So that's the reason that they are very powerful hip flexors, right? Because hip joint is in between, so they land on the femur. On the femur, obviously on the medial side, and this is lesser trochanter. Lesser trochanter. So that's the story of, say, psoas major, right? What about the psoas minor? Psoas minor is just this much, T12, L1, just thin, right? That is psoas minor. Psoas minor. It's T12 and L1. And it will land on iliopubic eminence. You remember ilium, ischium, pubis. So that is pubis, that is ilium. There is prominence over here, right? Which would be over here. So that is iliopubic eminence. Ischium is on the posterior side, right? We always sit on ischial tuberosity. So this is iliopubic eminence. So two muscles, one psoas major and psoas minor. Two down, right? Just two to go. The third one is that cousin of or the business partner of psoas major, that is iliacus, a triangular muscle. Right? Now, this particular muscle, its arrangement is, right? You know that it is the iliac fossa, right? A big one, right? The entire iliac fossa, that's from where it emerges. So, upper two-thirds of iliac fossa. That's why though it is called as iliacus, right? And from there, where it goes, we know that, right? It is the lesser trochanter because it goes along with that psoas major. So lesser trochanter on the medial aspect, right? And obviously it is femur. And the fourth and the last one. This is quadratus lumborum. We used to say is a very disciplined muscle, right? Quadratus lumborum, quad, from the shape. If we really want to understand that where exactly it is attached, once again we'll be drawing all those vertebrae. right? So all the way L1, L2, L3, L4, L5. Now, very interesting. Huh? See, we are watching from the posterior side, right? So that is the iliac crest, correct? This is the iliac crest. We are watching from the posterior side. This is posterior view. Change the color. And these are the transverse process, right? This is transverse process. So from L5, the transverse process of L5 and the iliac crest, the journey starts from there, right? And it goes all the way to this. So that's how it gets its shape, quad shape. So the point is that L1 to L4, right? L1 to L4, they are for insertion. Insertion. L1 to L4. Quadratus lumborum, very powerful, very important muscle, right? And origin from the iliac crest. Now, if you want to be more specific, we can say that it is the inner lip, right? The inner lip. It has to be the inner lip of iliac crest because the outer ones, so they are occupied by those gluteus, right? So, and an inner lip of iliac crest plus L5. But that's the key thing which you must remember. The transverse process of L5, that is where the origin is, and L1, L2, L3, L4, L5, that's where it goes. Also there would be say 12th rib over here, rib 12. So it's medial aspect, right? So few fibers from here onwards. So giving a proper quad shape, right? So the medial portion of the rib number 12. So they were the four muscles. So psoas major, right? And psoas abscess, very common. These are the areas: paravertebral abscess, psoas abscess, right? They are the commonest. And from the pathology point of view also they are pretty important, but we'll discuss it when we'll be talking about pathology. Otherwise, say this is a space which is, there is less space, so that's why the development of abscess that can really spread to other areas, right? Inguinal ligament, lesser trochanter, you know it very well. So I think that's it for today. And let me just check if I have put. Okay, I'll put some images for your practice. Yeah, I'll put that, right? So that you can nomenclature, you can do the nomenclature of those important structures. So thank you so much. I'll just save this thing, right? And I'll put it into our shared folder. Right. Thank you and bye-bye. Sure.